One.
Good evening, and welcome to part one of the New York Medical College Anesthesiology Residency Application Virtual Forum. My name is Norbert Smetala, former president of the Anesthesia Interest Group and currently the alternate student delegate to the American Society of Anesthesiologists. Today, I'm joined by my colleagues, Candace Dice, our M4 advisor for our AIG, and Ian Chow, treasurer of our AIG. We are all excited to host the first panel of 3 in our series of virtual application forums this year. For those joining us for the first time, the goal for tonight is to provide applicants with information about the application process, learn more about the wonderful programs joining us today, and to answer many of the questions that you may have about the upcoming application cycle. Before we begin, I want to thank our guests for joining us. Today, we are joined by Dr. Abramowicz, Associate Program Director of Westchester Medical Center, and her resident, Dr. John Bakar. Dr. Mahoney, Program Director at Mount Sinai Morningside-West, and his resident, Dr. Choi. And finally, Dr. Romanelli, Program Director at Montefiore Medical Center, and his resident, Dr. Benek. We also want to thank our faculty advisors, Dr. Abramowicz, as well as Dr. Weber, who have supported us behind the scenes to be able to host these virtual forums and all of our other events throughout the year. To everyone viewing on YouTube, we invite you to join us on our Slido, where you can submit questions anonymously. The link is in the description. So before we begin, I'd like to give each director 2 to 3 minutes to introduce themselves, the resident joining them, and a brief overview of their program before we get into our questions. We're going to be going in alphabetical order, so I'd like to start with Dr. Abramowicz, please.
Thank you, Norbert. How much time do I have?
2 to 3 minutes.
Okay, great. So I want to advertise Westchester Medical Center, which is the program that is really essentially the university hospital program for New York Medical College. So we do have a long-term 12-year affiliation with New York Medical College, but we are separate entities in terms of our budgets. Otherwise, we share the leafy campus and all the weather-related problems on this campus. We are very, very much the training site for the majority of New York Medical College students. And in anesthesiology, it's really the only training and rotation site. Okay, this program has been around since 1969, and it's been continuously accredited by the ACGME, and currently I just stepped down on August 1st as a residency program director, passing the baton to Dr. Sarah Smith, who has been associate program director for the past 3 years, and I am now her associate program director, ensuring a very smooth transition of the leadership. And I think, it's incredibly important that we do it that way, because it is a complex thing to manage a program, as I'm sure everybody understands who's been here. This is a completely seamless. We work very well together and know each other, and so that's great. The other thing I want to mention is that we are fully accredited for 52 residents. We are accredited without any citations or areas of concern or anything like that. And I am very much on top of everything that requires any intervention, so that we remain in full compliance and ensure that our residents graduate from a wonderful program where they're treated well and they don't get overworked, and enjoy cases that are of incredible importance for the development without doing what passes for scut work in anesthesia. That's all I have to say for now. And Dr. John Bakar will be happy to answer all your questions about lifestyle at Westchester.
Great. Thank you very much. Dr. Mahoney, your turn, please.
Thank you so much. You guys are all so well dressed. I feel kind of like a bum, but I'm thrilled to be here with everybody. I represent the Mount Sinai Morningside-West residency program, one of 5 residency training programs on the island of Manhattan. There are also some great programs not on the island of Manhattan. I don't want to cast aspersions on anybody here in this meeting. We are located in 2 different sites. We're Morningside and West because we're 2 hospitals. One is the Mount Sinai West Hospital on the southwest corner of Central Park, and the other is Morningside, which is near Columbia University. I like to think we're the best located of all residency training programs in New York City broadly, and I'll stick with that. We're close to Times Square, Lincoln Center, Central Park, Riverside Park. It's a glorious place to live and to train. and we have housing right across the street from Mount Sinai-West. What are we known for? Regional anesthesia is probably one of our highlights. We are the Orthopedic Center for Excellence for Mount Sinai Healthcare System. Our residents all graduate with a tattoo of an ultrasound probe somewhere on their body. John Choi is joining me. His is located on his lower back. He won't show it to you today. You're not going to graduate from any other program with the same facility using an ultrasound probe, not just for peripheral block placement, but also for access as well. Our residents wow me. When we need to use ultrasound for an A-line, I step aside. They are all better than I am. We have a variety of great cases. We're part of a large healthcare system, providing our residents with the ability to see anything they want to see. Furthermore, we're the only residency training program in Manhattan, which allows any rotations to other healthcare systems. So while we have many people come to our program for some rotations, Dr. Abramowicz sends some residents every year for OB. We love having him, and they're great, by the way. She has outstanding residents. We also host SUNY downstate residents for cardiac, Sinai residents for regional, but we have the ability to go to Memorial Sloan Kettering and Children's Hospital in New York for a couple of our rotations. That being said, 90% of our residents' time is spent on site. We have a great class. We're the smallest program in Manhattan, and I think that's one of the reasons people like to come here. We have the smallest faculty group, I think, of almost any residency training program in the city, maybe not MIMO. But what that means is you know all your faculty, they all know you. It's a happy family. I think it's one of the best work environments you can have during residency. I'm joined by my outstanding CA now 2 resident, John Choi. He's actually doing an elective rotation for adult cardiac right now on the Mount Sinai East Hospital campus, and he will answer any questions you guys have about the experience of being a resident in our program. And if you're really nice, he might show you that tattoo.
Great. Thank you very much, Dr. Mahoney, for that wonderful introduction. Dr. Romanelli, you have the floor.
Sure. Good evening, everyone. My name is Eric Romanelli. I am the program director of Montefiore Medical Center. We're the official hospital of the Albert Einstein College of Medicine, which famously recently went tuition-free. I'm a resident alum of the Montefiore Medical Center program. I really take pride in our program that really gave so much to me, and I can attest for recent alums over the last 10 years who I've gone on to do really incredible things in anesthesia. But it's really given me so much in terms of my training, the flexibility, the adaptability, the versatility, the foundational leadership skills. And I think the reputation from training at a place like Montefiore really does go a long way. We have very high volume with a very complex patient population who are often presenting quite far into their disease pathology. So it's a really unique educational opportunity for our residents and trainees. And I think those are things that you should want out of a residency program. You learn to become very well-versed and adaptable and independent very early on in your training. A little history, we were first accredited in 1960, so we're in our 64th year. It brings to mind for me the Beatles song, "Will you still need me? Will you still feed me when I'm 64?" And so the answer is a resounding yes, we're still needed. Our residents are essential not only to the success of our program, but also to the community that we serve. So we continue to feed it and cultivate it with fresh minds who make the merits for me and all my colleagues working in an academic center all the more favorable. And so we'll turn 65 this year, and we're technically Medicare eligible, but we're anything ready to retire at this point. So every year we invite about 17 residents into our program. That's 11 categorical and 6 advanced positions. We have 7 fellowships. We've got OB, regional, pain, neuro, critical care, forgetting something, probably peds, cardiac, I think I said. We do a little bit of everything, with the exception of trauma, I would say. We are a level 4 regional perinatal center. We get high-risk OB referred from all over the tri-state area. We're an ACRETA center. We're a comprehensive stroke center. We're a joint replace center and naturally perform a lot of blocks as well across our 4 different sites. Gertie Marks trained here. If you're not familiar, she's the mother of OB anesthesia and the namesake of Gertie Marks needles. We developed Fioricet, which maybe some of you have ever used for a tension headache, or it's really good for post-dural puncture headaches as well. And then we're also the official hospital of the New York Yankees. So get many opportunities to attend games with seats that are technically free. You have to pay a $2 service charge per ticket. Maybe they'll abolish that part, but that's Ticketmaster. They're a little snarky that way. And I'm joined by Kirk Benak, my excellent chief resident, who I know is going to go on to fellowship next year over at Cornell, joint cardiac and ICU, and I'm super proud of him. Kirk wants to introduce himself.
Hi, everyone. Kirk Benak, I'm the resident of Monty, joining. Glad to answer any questions you might have. And thank you for the introduction, Eminem.
So thank you very much, everyone, for those introductions. So without further ado, we're going to proceed with the Q&A. As for the format, we want to give each director equal opportunity to answer first. So the way we're going to do it is we're going to ask the question to all the directors and then ask them to respond in alphabetical order. And with each subsequent question, we're going to rotate who starts first. So for the first question, I'll ask it Dr. Abramowicz answer first, alphabetical order after. Second question, Dr. Mahoney will go first, alphabetical order. And then third question, Dr. Romanelli will go first, alphabetical order. And then we'll rotate that until the hour is up. We think that's the fairest way to do it so that each person has first opportunity to reply first. So for the first part, we're going to be asking questions about general overview questions. So for everyone, what are a lot of you mentioned things that you're proud of about your program, but what are you most proud of about your program and what makes you stand out among other programs in the area? Dr. Abramowicz, can you go first, please?
Okay. I'm very proud of several things. First of all, we love our residents. We like to retain them. With the job market where it is now, not everybody wants to stay in a trauma center, and burn center and transfer center and transplant center, etc. But I would say some of the best attendings we have, like really the paragons of clinical prowess and expertise, are our graduates. So that's a very, very big deal. And the other thing I'm proud of is our residents, because Dr. Romanelli mentioned, no trauma at Monte. I used to work at Montefiore, and I agree, it's a very challenging clinical environment. But we, I think, are a better representation of America at large, because even though we're very close to the city, about 35 miles, we are really a catchment area for 3.5 million people who live in rural New York. And so we have a completely different patient population, very diverse, but also extremely underserved. And you can say whatever you want about New York City and all these boroughs, but all the health clinics, they're really very close and within walking distance to most of the population. For us, it's very different. So I am very proud of the fact that we're serving this diverse patient population, and our network is reaching a lot of people, and we're very, very proud of this. We have an incredible pediatric hospital. We have grown our OB, Dr. Mahoney, from, we've doubled actually our volume. We've become a SOAP Center of Excellence and an ACRITA Center. Yeah, it's a very, very dynamic environment. I'm very proud of the fact that we're about to open a major critical care tower, which is going to have close to 100 critical care beds. And that the ground was broken for this. We are hiring people who are critical care trained, and we're expanding the reach of the anesthesia department into everything that is critical care here. And that is what perioperative medicine is all about. So even though we're the masters of everything, burn, transplant, trauma, pediatrics, whatever, we are going to be taking over critical care here very, very soon.
Sounds like an exciting time. Looking forward. Dr. Mahoney?
Thank you. Well, I had the privilege today to do a mock oral with one of our new faculty hires, and she's a cardiac trained physician. Before we started the practice test, I asked her about her experience, and she's worked in 3 other academic programs with residencies, and she was raving about our residents, which I love to hear. So I'm most proud of the fact that we produce the kind of people that new faculty rave about when they come. She mentioned their attitude, their amazing work ethic, but you know what? I would like for Dr. John Choi to talk about what he thinks makes these new faculty rave so much about my outstanding residents. Come off of mute, John.
Sorry, I'm having technical difficulties. Hi, thank you so much, Dr. Mahoney. What I'm most proud of about this program is the kind of support that you get from people like our amazing PD, Dr. Mahoney. The kind of environment that we get beyond in the OR, the friendships and networks you build with the faculty, not even just the faculty, rest of the people in the department, like admins and coordinators, the kind of camaraderie and the friendship that we build here is just uncomparable, in my opinion. I get tons of support in and outside of the OR. I don't think I have to speak too much about our clinical education because of the kind of cases and the case volumes and varieties unmatched, I think. But beyond that, the environments that everyone creates, including your co-residents and faculties, is also really unmatched. I can't be happier here, and I'm really proud to be part of this family.
That's great. It sounds like you're in a very supportive and loving environment. I love to hear that. Now, Dr. Romanelli?
So I'd say, I'm most proud of what ultimately develops throughout the residency program amongst our trainees, which is really bringing them into our communal mission to taking care of the Bronx community. It's a very disadvantaged population who are very far into their disease pathology. And I think that it does present a really unique educational opportunity that it really allows our residents to be well versed in the pathological implications for anesthetic care, and they become really readily adaptable to take on high-risk cases, sometimes without the liberty to fully optimize these patients because of the urgency. I'm also really proud that we have a very homegrown crew like myself, but then many from surrounding New York and other institutions from all across the country. And, we use that to our advantage. There's multiple ways to approach an anesthetic, provided it's evidence-based, and no two anesthetics are going to be exactly the same. And so we're able to get our residents communicating at the near level of a perioperative consultant by, the midpoint of training, because they've absorbed via osmosis all this varied expertise. And what makes us maybe stand out for New York, I can really only compare my experience. I did a brief OB anesthesia fellowship over at Columbia, in which I'd say maybe we have a nicer crop of surgeons. But it really all comes down to the Bronx again. We're burdened by a series of health challenges and socioeconomic circumstances that just naturally foster poor health outcomes. It's really the least healthy county in all of New York State. And there's a lot of factors that make our population vulnerable long before they're meeting us. There's unstable housing and unemployment, limited access to healthy food, women with lack of prenatal care, poor health literacy. And each patient brings something else to the table, and we can only really deal with the hand that we've been dealt. I think our residents, they're really just prepared for everything, and they get this really routine exposure to complex cases that just really helps their overall foundation of training. And you don't get pigeonholed into thinking there's only one right way to go about an anesthetic when you're dealing with that kind of repetition of complex cases, or thinking that you have to, comply with surgeon demands, that there's no time for a regional block. So I think that's basic nitty-gritty of it.
Thank you. It sounds like a really interesting environment to work in.
Sure is.
Now I'm going to pass the baton to Candace. She'll be asking the next question.
Thank you, Norbert. So my first question is going to be for Dr. Mahoney, and you actually already started touching on this, so hopefully you'll enjoy this one. But using 3 adjectives, how would you like your program and residents to be described by others?
So we got no prompting about these questions, and this is a hard one. three adjectives.
You can use fewer if you'd like.
No, I'll go for it. How about this? I'm going to give an adjective, and then I actually have been joined by my chief resident, Jen Salick. So like all good leaders, I'm going to learn how to delegate some of the task. And so I'm going to start with supportive. I think it's really, really important for people. They're coming out of medical school. They're scared. They're nervous. When they're going into anesthesia, they don't know how to do any of it. And I think it's important to make a safe learning environment where people feel supported to take challenges, to get outside of their comfort zone, because you're not going to learn if you stay in your comfort zone. So that's one of my main goals for my residents, And then I'm going to pass the baton to Dr. Salick, my amazing chief resident, and then John can bring up the rear.
Yeah, I was gonna say, I'll give one adjective, and then because you taught me so well, I'll delegate again to John Troy, and he'll give the third adjective. I guess like kind of going along with this is maybe not an adjective, but with the supportive, I think also that our program is very good at fostering autonomy as well. The training is really great. You know, you always have an attending there to support you, and is always willing to back you up, and also your co-residents as well. But they also give you the freedom and the flexibility to progressively gain more autonomy, and as you go, you get really comfortable taking care of patients on your own, with your attending always in the background supporting you. And I think that it's kind of a great mix of both worlds, where you get to do a lot on your own and you always have an attending to back you up. John Troy.
One day I'll be a CA3 or, you know, a program director, and I'll delegate too. I think a good third word would be approachable, an adjective, approachable. I think, again, I'm really emphasizing being in a supportive and, you know, this kind of a camaraderie like environment, but I think being approachable is really key to creating like this open and communicative environment where you feel safe and included to really talk about anything with your peers and to your faculty members. You really want to feel comfortable in a hard-working 4 years of your life, and go to your program directors or anyone for that matter with any concerns or ideas and feedback. As you know, feedback is really important to better yourself, especially in this critical times of, you know, your training years. So I think approachable is a good third word.
Well, thank all three of you for showing us some masterful delegation. I'm hearing supportive, autonomous, and approachable. And I'd like to throw that same question over to Dr. Romanelli next.
All right, get ready, Kirk. No, let me see. I was gonna maybe use a hyphenated one first. I'll probably say team players. Maybe you can even make that one word, but I think it's just so important that, you know, you can have all the smarts in the world, but if you're not a, you know, team player, it doesn't, and someone who thinks they know everything and doesn't incorporate faculty feedback into your practice, and you don't listen to your fellow co-residents, it just doesn't really translate well into this field. So it's so important. I think we kind of have like a litmus test at this point. You're like who's going to work really well with me when we're involved in a crash section at like 2 a.m. You know, who are going to be the people who are going to like rise to the occasion and who are going to, you know, really contributed to the team, and not just the team, you know, internally with the anesthesia, but also with our surgical colleagues, with our nursing. So it's so important that we learn, you know, this like kind of interdisciplinary collaboration. So team player to start. I will say resilient with the reservation of, I don't like the word actually, just because, and I think it needs to have kind of more of a definition these days of more so. To have resilience to me means being able to advocate for yourself and for others. Not so much, you know, that you like you've got this like kind of fortitude that, you know, you can just take on anything and not, you know, brush anything off your back. But to me, resiliency really needs to be kind of taken in that newer context right now. So, and that's something I think I see, especially for our residents, that they're very focused on their well-being, and they've in turn, you know, forced us to kind of look to say, you know, number one, like, are we as faculty as well taking care of ourselves? Are we modeling good professional behavior in terms of the way we take care of ourselves? And then, you know, making sure that they are able to have an appropriate work-life balance. It's super important because we are working very hard. We know that there's high rates of burnout and stress and that are associated with this field particularly. And it's just so important that you really can advocate for yourself, because at the end of the day, it's what, you know, it's what you're also bringing to the table when with every patient encounter, essentially, that, you know, that you are a person of, you know, good well-being yourself, and that when you have to be in that mindset in order to take care of a patient successfully. And then maybe I'll throw one over to Kirk.
Hi, I'll take that. I'll take one. If I had to use another word to add to Dr. Romanelli's, I'd say adaptable. And I think this is true on both the resident and the attending level. Just to start, we have many attendings that I think, while they do have their specialties, they really pride themselves on having a very broad scope of practice and being able to take on a lot of different cases, some that they don't see as frequently. And I think as residents, we're exposed and we're in a larger variety of cases more often, but I think that's a characteristic that we all try to emulate. And so I think we have a lot of good role models for that. So I'll leave it there.
Thank you both for your responses. So I'm hearing collaborative, advocates, and adaptable as a way to describe your residents. And I'd like to finish with Dr. Abramowicz answering the same question.
All right, it's a little rigged, but hey. Okay, so I will say the thing that I think defines our best, I don't know if it's an adjective, but we are a non-hierarchical department and program. And if you can talk about healthy dysfunction, every large medical center has dysfunction, especially in the Northeast. We are, I think, the model of normalcy in dealing with dysfunction. And I think that these are sort of the defining characteristics of the program. Bianca, I'm sure, is ready to chime in, but I will say one more thing, that what defines the way we teach and we want our residents to approach our work, which is often chaotic and disrupted by emergencies, is to critically think before they do. Bianca.
I'll say I think we're very collaborative. I would say, since being a CA3, I think there's a lot more autonomy, there's a lot more trust. I think especially with the acuity of cases we have, the types of cases we do, we get a lot of great experience in our CA1 and CA2 years. And so I think because of that, by the time we're CA3s, we have a lot of trust from our attendings. And as a result, we have a lot of support, and we get to kind of be like pretendings for the year, both on call and just in general. A lot of the attendings let us induce, they let us intubate, they just stand kind of indirectly supervising, so like in the room, but not hovering over us. They might put in an IV while we're doing our intubation. So it's very nice that we work really hard, but we also have very good hours. So I think we have time to rest and refresh, and I think it really prepares us well.
Nice. Thank you both for chiming in. Since you were last, I guess we can get away with 4 adjectives. So I'm hearing non-hierarchical, healthy dysfunction, critical thinkers, and collaborative, which is great to hear. And for the next question, I'll pass it over to Ian.
All right, thank you, Candace. So the next question is going to be maybe a little bit difficult to answer and maybe a little bit vulnerable, but are there any areas in your programs that you have identified as not as strong and are working to improve on? And if so, what changes do you expect to have to the program by the time current applicants are CA1s? So we'll start with Dr. Romanelli.
Cool. I think I talked about this last year, actually, was that we were having, when I inherited the program as program director, one of the major areas that was identified on our ACGMA survey was that residents were dissatisfied with the faculty feedback that they were getting. So that was an immediate mission that I took upon. I want to say it was like something like 45% satisfied, so maybe like 55% dissatisfied. So immediately kind of took it upon ourselves as a department to even kind of make this into a quality improvement initiative, bringing in, we spent an inordinate amount of money apparently in trying to link, we use Epic as our EMR, but it linked essentially Epic assignments to automatic generation of new innovations evaluations. And it's had great success, actually. So I think one of the biggest things was that faculty would kind of forget if they weren't doing it in a timely fashion. They kind of forgot who they worked with. So just to kind of even have that kind of log of who they worked with helped out extraordinarily. My issue now is we've got the quantitative number. Now it's more about the qualitative feedback and making sure that that feedback is honest and appropriate and, is constructive. So now kind of really more so working with the faculty and making sure that, the feedback that they are providing, because now it is numerous and sometimes it's almost overwhelmingly positive, which is great. I'm really happy about that. But then, when there are potential like residents who are starting to have some kind of issues, I'm like, okay, but like that's like the needle in the haystack now. It's like, so it has to be kind of like we're trying to get it to be more balanced. So that's kind of the general conundrum that we kind of face. But overall, it's just so important that you're in a very constructive environment where people feel open to actually give feedback critically. What we're dealing with is, to be blunt, it's life and death sometimes. So you have to really take that seriously, and the onus is upon us as attending physicians to make sure that the training process is going the way that it's supposed to, and that you are meeting your clinical competencies and you're meeting your milestones, and that you're acting at an appropriate level for your training. So that's something that we continue to work at, and I look forward to the challenge ahead.
All right, thank you, Dr. Romanelli, for the honesty and transparency. It's something that we all appreciate.
And then
we'll go with
we were 90% on this past survey, so we rectify.
That's great. Now going on with Dr. Abramowicz, same question.
So, a program that doesn't evolve is a dead program. And although I have to say, I am passing on a very healthy program in very good shape, we do have some areas where, we try to improve, and that is our resources. So those of you that have been here, we know very well, we have a gleaming, beautiful new building called the Ambulatory Care Pavilion, which actually opened just before the pandemic, and that's where we moved all of our ICU patients to convert the ICUs into COVID ICUs. We had over 200 ventilators in the hospital during the pandemic, so we really that served us very well. And that beautiful new building is connected to the old operating rooms, which are really, some of them are ridiculously tiny. And, it's like a danger to health and limb safety, when you have to maneuver some of the equipment that we want. So this is something that we were actively working on. And that also pertains to resources to provide our residents with a brand new touchdown space, which is in construction right now. We're on hold because we're missing doors. I thought the supply chain problems were behind us, but apparently not. And brand new call rooms. So this is something that we're working on. We're working currently. I am currently working on the budget for wellness with our GME. We are the third largest program in this hospital. So when I told them that, there are some programs that advertise online that they spend $75 per resident per quarter, they quickly did the math and they were like, well, we want $30,000. But, I had no idea that I was a hustler, but turns out that I have some gifts. And I am very hopeful that maybe that 30,000, I went all out, but we will get some money so we can go 50 of us kayaking on the Hudson River. I know that our OB residency does it, but there are only like 12 of them or something. So that's where we are. Money, money, money. Please give me money. I like the third grade project. My son said, like, you have $1 million. What do you do with it? I don't have any money, but I know what I want to do with it. So that's that.
All right, thank you, Dr. Abramowicz. I really liked your quote about how a program that isn't evolving is a dead program. I think that's something that every program can really look into. And lastly, finishing with Dr. Mahoney, the same question.
Thank you. This is like a really popular question for applicants to ask during interviews. My answer is the same as it's always going to be: everything. I think everything can always be better. Now, the question is, where do you put your resources? How you decide what you're working on? We have things like surveys, we're responding to changing times. Right now, the biggest issue we're all facing is the national shortage of anesthesiologists. All of us are coping with that. And I'm sure Dr. Abramowicz and Dr. Romanelli are also coping with that in their own way. They have a lot of support from their departments. I know people there, they're doing a great job. I like to be guided by my residents, so I am a feedback junkie. We have so many mechanisms for feedback. In fact, just this morning, this morning, Dr. Salick and Dr. Choi arranged our confession session where we get anonymous feedback from our residents. I have an email full of things that came up. I have answers to all of them, Dr. Salik, by the way. The coffee machine will be provided. Dr. Choi actually donated one already. So I look for them to also tell me. We use our ACGME annual survey. We use our in-house annual survey. We have a Google Doc that is anonymous. So if someone's sitting in an OR and something's really bothering them and they don't want me to know it's them who's being bothered, they can use the Google Doc and then anonymously submit it. We check those. So honestly, everything can always be improved. And even if you think you achieve perfection, the conditions around your residency change, you have to improve things anyway. So Dr. Abramowicz is totally right. If you're not evolving, you got a lot of work to do. Dr. Romanelli is totally right, because his feedback thing was like the ¡1 complaint of all residencies in the entire country, along with intraoperative teaching. Those can always be improved for all of us because residents keep on telling us. But I think the best way to guide that I found is feedback.
All right, thank you, Dr. Mahoney. I love that idea of anonymous informative feedback. I think that's something that's becoming more popular, and it has been very effective. And I just wanted to say, I think it's very admirable that a lot of all the PDs discuss improvements that their own programs are striving towards. My colleagues and I find these really strong qualities for a strong residency program, because not only does it show humility, but it also shows recognition that there's always room for improvement. And there are very strong characteristics to have in not only a program, but also as a practicing doctor. And with that being said, I will now give the baton to Norbert with the next question.
Thank you very much. So now we're going to be transitioning to a couple of questions about the application process and interviewing season. So I'm just going to start off with a broad general question. What does your program value most in an applicant? Dr. Abramowicz, can you go first, please?
I anticipated this one. So first of all, I want to say that we are expecting hopefully fewer applications this year than last year. Maybe the fact that this 15 signal process does signify a soft cap. We have some data that are coming out soon from our association that show that really, if you place your signals correctly, you will get an interview, and you're very likely to match those places. So that's one. But for us, this is what I want to say. We do not decide who we match. We only decide who we interview. Correct? That's how the algorithms of this system that we did not design and do not all love works. So given the current situation, meaning the number of applicants, last year there was something like 4,500 applicants for 2,200 spots. We prioritize American seniors. That is now our #1 priority. We prioritize signals. We prioritize geographic preference. So that's sort of the general gist of it. We are going to read those applications that fill this criteria very thoroughly. We have a standing recruitment committee, very experienced people who have reviewed a lot of applications. Usually they specialize in certain schools, so they understand how to read the MISPs, etc. And we will select those that fit our internal criteria for interviews. What are the internal criteria? Well, we're working on it because we would like to use Thalamus, which is an AI overlay, to help us decide, in a very holistic, and because we understand every reviewer has some biases, which are, most of the time unconscious. And so we are going to we are going to get help from that AI overlay that the Thalamus cerebellum has. We will also try the Central app, which also has an AI overlay, which wasn't very well trained on anesthesiology applicants. That's why we're using both systems right now. So we are looking for one major criterion. We are in a trauma center. This is a very dynamic environment. When I say dynamic, that means that if you think you're going to be in room X doing case Y, it may or may not be the case when you come to work. And we need people who are adaptable. people who are adaptable, can see themselves thrive in an environment where things change, and actually get a kick out of it and love it. Because if you are a very rigid person and you get very anxious and stressed, if they're going to move you from room A to room B, I don't think you're going to do well at Westchester Medical Center. That's the honest truth. We pay attention to academics, very much so. You have to be prepared, and they have to have a track record of not having, even if you had a failure, you had to have picked yourself up and done better. Because in this environment that we provide here, clinical learning environment of our institution, you cannot fall behind. If you fall behind, it's very hard to catch up. Talking about academics, our subspecialty rotations start in block 6 of the first year. So you have to be ready for this. And I think I'll end it there because I can talk for a while, but let's see what the others have to say.
As someone who did all my rotations at Westchester Medical Center, I definitely agree with you after participating in trauma codes that there are definitely students who thrive in them and students who do not thrive in them. So I see your point in that. Dr. Mahoney?
Thank you. Dr. Abramowicz brought up some great points. Signals matter a lot. I think that almost every program you're looking at is going to heavily weigh them. But in general, when we're trying to put together a great class, the goal is to make the kind of environment where patients get the best care and people love coming to work. And so you're looking for certain characteristics, certain traits people are going to bring with them every single day. I'm extremely proud of the fact that we have one of the most diverse residencies in the country. We have the highest percentage of women of any residency program in America, anesthesiology residency program in America, for over at least a half of a decade. Despite the diversity, I feel as though our residents all share some common characteristics that make them the kind of people that patients want to receive care from, that their co-residents want to work with, that maintain the joy of teaching their faculty have. And my chief, Jen Stalick, is going to talk about those kinds of traits that she and all of her classmates. I put her on the spot, so forgive her. I'm totally putting her on the spot.
Yeah, I think, I haven't gone through an interview cycle yet. This will be my first year since I'll be interviewing as chief. But I think kind of something that all of our residents have in common and something that I know I'll be looking for in this interview season is just someone who you want to be on call with in an emergency at 2 a.m. in the morning when shit's hitting the fan and, a lot is going on at once. Just having someone there who you enjoy being on call with, who you personally, who you get along with, who will have your back in very tense and high stress situations. And so I think someone who kind of embodies that and can fit into the system that we have is kind of someone that I would say.
Awesome. Yeah. I think what you're describing is that you want to go to work and be with the people that you're around and not dislike going to work. So I definitely understand why you're looking for people like that. Dr. Romanelli?
And I think what Dr. Abramowicz was getting at, I think, essentially is that, the match is meant to work in the applicant's favor, ultimately. For us, I think we're always looking for the personality characteristics. I think by virtue of getting an interview, we kind of have already kind of said, we can probably trust you with regards to your academic prowess, but now it's about, are you a personable person? Are you professional? I agree with the idea of looking for people who have that adaptability and flexibility, because that is the current job market right now. They're looking for these Jack and Jacquelines of all trades who can do just a little bit of everything, who can, bounce from, complex ortho to OB one day and then do peds and then who knows, do like outpatient cystos the next day or a bunch of opto cases. So I think that's, we're basically, and Dr. Mahoney gave me great advice last year, which was like, go right for the comments section in the MSPE section and, see what people are saying about the residents, medical students then, about what are their, personal traits that, transcend into how they might, work in a team-based environment. I do get a lot of questions, about, whether or not people need to round out with research. I don't know if we're going to get to that, but, it's important that you do present yourself as a well-rounded person, and research necessarily doesn't have to be the end all of that. We celebrate people with, wide, varied interests, and we want to see, passion for something. I think I'd be remiss if I didn't mention, what's going on in the job market right now, that we have very low numbers of graduates who are going into academic careers, even lower numbers, it seems, who are going into fellowships. So, when we meet people who have these, academic proclivities, whether they are research, QI, or education, I know our recruitment committee starts thinking, well, how can I mentor that young doctor and, provide them with our institutional resources that can give them a leg up on an academic career? Because 5 years from now, we're going to be, we're going to be in trouble if we don't start, filtering that back in. Whereas when I was, applying, it almost seemed like you needed to have a fellowship in order to get a competitive job. Right now, it's, private practice is dangling a carrot that people are very apt towards taking quite quickly. So it's kind of, for us, we're trying to be a little more forward thinking in this application cycle, not necessarily saying that if you have an inclination already that you want to go into private practice, that, you're out of the ball game, but thinking about still, how can we, help you get scholarly work done during residency, and maybe helps you see the light and the merits of working in an academic career.
Thank you very much. So it seems like, in summary, for all three programs, once your application reaches a certain benchmark, it's really just depends on if you're a dependable, adaptable, reliable, and likable person is what you're looking for in your programs.
And it's so hard to gauge
so now
from
I'm
a
going-
15-minute interview too. You have to understand.
Yeah.
Like, but
It's what stresses the applicants out. How are we supposed to convey that in that amount of time? But yeah. All right. Thank you very much.
I don't think you should be stressed. If you're yourselves, it really comes through.
Thank you. Okay, I'm going to pass it back over to Ian now.
All right, thank you, Norbert. And with that transition about talking about stress, we obviously know that anesthesia has become so competitive, and away rotations have actually become a lot more popular. So our question is, what are your expectations for students during away rotations, and in what ways do you think these experiences can impact an applicant's chances of securing an interview and ultimately a position in your program? So I'd like to start with Dr. Mahoney.
Let's do an anecdote. It was years ago, and I was coming up to labor and delivery for my day, and there was a bright-eyed, bushy-tailed medical student standing next to one of our epidural carts. And she introduced herself, said, "Hey, Dr. Mahoney, I'm assigned to be on OB with you today." And I was like, "Great, let's get to know one another." So we restock our carts every day. We have two. So we take stuff out of one, put it in the other to take the empty one back and restock it. So I start moving things from one cart to another while I'm asking her questions. While answering my questions, she sees what I'm doing and instantly starts doing what she knows she can do. She can't do anesthesia, she can't place an epidural, but she can see that I'm transferring some shit from one cart to another. So she intuitively starts doing that, handing me things, we're working together, having a conversation. By the end of 5 minutes of stocking the cart, I knew I'm going to rank this woman to match. Because she walked into a new situation and she knew that she couldn't intubate. Maybe she could or couldn't place IVs. She doesn't have the knowledge, but she recognized what role she could play, and she immediately and intuitively took on that role. That's the most that we can ask you when you come to us. If you try to show off your airway skills, you're going to fail because you can't intubate anybody yet. If you try to show off your anesthesia knowledge, maybe you will or you won't, but you might piss off the resident who actually doesn't know all those answers to those questions. So you want to show that you're able to adapt and find a role, because honestly, when you start anesthesia, we're all going to tell you, Dr. Romanelli, Dr. Abramowicz will all tell you the same thing I'm about to tell you. Focus on the things that are within your control, and the rest of it, we're going to train you. Bring a great attitude, a great work ethic, and slowly expand that circle of what's within your skill set. And in the beginning, that starts with, well, I don't know anything about anesthesia, but I can know my patient. I don't know anything about anesthesia, but I can have my OR set up. I don't know how to do this case tomorrow, but I can call a chief resident and ask for advice and have everything ready and look really good. So she already showed that. And that's the kind of thing that you can show when you come to a new institution.
Thank you for sharing that anecdote, Dr. Mahoney. I think that's something that we can all learn from if we're doing aways. And I'd like to now toss that off to Dr. Romanelli.
Yeah, I basically agree with all of that. I was personally confused by Einstein College of Medicine was almost telling their students, I don't know if anyone is in attendance, but the advising was almost to tell them that they shouldn't do away rotations, which I personally kind of disagreed with. If anything, it's an opportunity to get to know another program outside of your own home institution and get to see how things are done in a different environment with different folks. Learn again that kind of flexibility and adaptability that comes with working in a different environment. There's a lot of different unique opportunities that you can likely immerse yourself in. But sometimes there can be this kind of element that it might be a make or break experience, and you have to kind of be cognizant of that. If number one, if like you're just like not showing up or you're not engaged, that's gonna be recognized, especially if you're like on a sub-I and they just like know you as the person who kind of like just ducks out around 12 p.m. because that's kind of how when I meet medical students who are just like on their elective, we have ones who come to us just for a week when they're on their surgical rotation, and I'm like, why don't you just go home and study? I get that you don't want to be here, but when it's one of the sub-I students, I kind of do expect that they're going to be around and that they're asking questions and that they're trying to be actively involved. And it's great because you do get an exposure to our culture. When residents come to us in July, I think it's always kind of also an interesting experience because they're witnessing the mentorship period, the one-to-one, and they kind of see how that is intentionally strategic for how we kind of start to loosen the reins when our new residents are just coming into the field. So maybe they're not getting as many procedures, but the ones who I've really seemed to bond with already, like they are cognizant of that fact that like, okay, yes, you do probably have to focus on the residents that you're training towards having more conditional independence at this point, but how can I still help out right now? And those are like just really good stimulated discussion. And when I'm trying to compare people who are on equal playing fields, who yes, I've only interviewed for maybe 15 minutes versus someone who spent a whole month, and I can kind of say yes, they were personable, they were reliable, they were professional in all their interactions, and everyone seemed to like them, and I think that they could be a good fit for our program. Maybe it could be a little more of a slam dunk, but still in the end, the whole rank list is it's meant to be in your favor. So however, it's basically, is there that reciprocity? Did they feel the same way? Like whatever, admiration feeling we feel towards them, is that reciprocal back towards us? So it's still not, a guaranteed slam dunk always.
Thank you for sharing that, Dr. Romanelli. It seems like it could either be a step back 3 or you can completely brick it in totally. So it really depends on the person. I thank you for sharing that. And lastly, with Dr. Abramowicz, could you share us your opinions about this?
So this is a very complicated topic, and I have a lot of advisory experience, a lot, because the New York Medical College is a large school, and every year we send approximately 20 people to various anesthesia programs throughout the country. So I do have some insights here. The problem is this, that you have to make these decisions very early in the spring. You don't know how competitive an applicant you are, because ultimately step 2 matters. And so my advice to people is always this: if you are very competitive and you want the program of your dreams, because you guys have no idea what program is a good fit for you, like how would you know? But you have that notion that that's where you want to be. Yeah, I think you should go and get that place out of your system or into your system. Go, take a chance, see if you fit in, if you like it. Now, if you're less competitive, it is going to be a month-long interview. Okay. Now, oftentimes people don't do well during these long, away rotations because they don't feel good about themselves. They feel insecure. They try to show off, as I think Brian said. That kind of colors, the whole impression. So I think that it really depends on the individual. I would completely agree with that. And ultimately, if you really know that you want to be an anesthesiologist, it probably is not all that important to go elsewhere. But if you still have some doubts, and if you really don't know what type of setting you would be best suited for, is it a hard driving, competitive academic setting, or more of a sort of laid back, like I told you, we are an academic place and we have 2 board examiners among our people and we publish, but we don't take ourselves seriously at all. So you want non-hierarchical, come on over and it's going to be great. So by all means, go and check it out, I think that's the best I can do at this point.
All right. Thank you, Dr. Abramowicz. And I want to thank you for being transparent about away rotations and how they might not be great for every applicant. And that's something that they should really think about. And so now with that being said, I'd like to pass the next question to Candace.
Thank you, Ian. So as we head into some of our final questions, out of respect for everyone's time, I want to give the residents a chance to respond. So this first one is going to go to Dr. Benek from the Monty team. So how does your program help residents to transition from prelim year to becoming an independent CA1? And what was your experience like?
I think I'm off mute. All right, thanks. Yeah, there are a number of things. Probably the biggest thing is there is a period of time prior to the start of CA1 year where they are mentored with senior residents and attendings. And they essentially are phased in. It's generally well recognized that the start of anesthesia can be a fairly steep learning curve. And so being able to work with both senior residents and seeing how they navigate that, as well as an attending who's more senior, really helps, both in terms of getting a sense of what knowledge they need to learn, finding the gaps, what kind of reading needs to happen prior to the start of CA1, in addition to just logistics, scheduling, and oftentimes with the resident mentorship period, they learn a lot of tips and tricks on, really just how to transition. So that's probably the most direct thing. And then beyond that, once CA1 starts and towards the end of the intern year, there is sort of a more formal didactic curriculum that's delivered in an attempt to sort of make the steep learning curve less steep, if you will. Does that answer your question?
Yeah, absolutely. So it sounds like in addition to didactics, you're doubling down on the collaborative adjective where you get to learn from the seniors and attendings.
Sure.
Perfect. All right, I'll have the same question go to the Westchester team with Dr. Jambakar.
Hey, so I think, especially in comparison to when I was an intern, the intern year has gotten so much better in terms of having anesthesia time. Like it was fine when I was there, but now we do, I think, 6 weeks of general anesthesia, and it's the same type of thing where you're shadowing a senior resident. You're basically learning like the day-to-day of anesthesia. The expectation is that it's a rotation where you get to learn, but also relax. It's not meant to be really rigorous. It's not meant to be, you have to learn how to intubate in these 6 weeks. It's more of a chance to get to kind of see the type of case volume we have at Westchester and really just see kind of how anesthesia works, which is, I think, a great thing for when you start as a CA1. You also get 2 weeks of POCUS, you get a month of pain management, I think 2 of chronic, 2 of acute, and you get quality improvement. So there's a good 3 months of anesthesia, I think, in the first year. So you get really good exposure. And then as CA1s, you get to be one-to-one for the first 2 weeks with a mentor, and the mentors they all choose are really great, and they're really invested in helping the CA1s. I still know who my mentor is from CA1 year, and she's always really proud of me when she sees me in the OR. And you also don't take any call for those first few weeks. So you get to go home at 5 every day. You have lecture every day, so you'll have didactics at the end of the day where they talk about the basics of anesthesia. And I think even after you start taking call, we're pretty mindful about making sure we're not having you take the same call schedule as a senior resident. So we kind of slowly incorporate it. And looking at our CA1 class for this year, you can really see that all the extra time in anesthesia has made them very prepared, and it's really awesome.
Thank you. So it sounds like that prelim year exposure is really beneficial to kind of get a preview as to what the CA1 year is going to be like and extra preparation.
I think,
and that's
jump in, Candace. I just want, because Bianca mentioned that we have been evolving that PGY 1 year like very actively, and it looks like next year is going to be the same as this year. So what I want to say is the following: you get 8 weeks of internal medicine floors, 6 weeks of internal medicine night float. You have to learn how to work nights. That's 14 weeks, and that's about all you see of internal medicine floors, okay? Then you do 2 weeks of cardiology consult, 2 weeks of renal consult. You have 1 week of backup. You sit at home and wait to be called in. You have 1 week of medical education when you can be actually a resident from Hawaii if you'd like. Nobody wants you here. You may have a small project, but that's all. So you can study or you can do whatever you want. Then you do 4 weeks of emergency medicine, 8 weeks of ICU, medical ICU, and 2 weeks of CCU, where you learn, about arrhythmias and impellas and things like that. We are a major circulatory support center. So this has become I love this year. I think that, all the CA3s walk around and say, I wish I had that kind of PGY 1 year. I think we finally struck the right balance, and I think it's going to be really, really great and the pain we split. We had some chronic, now we're doing 2 weeks of acute and 2 weeks of chronic pain.
Got it. Thank you for the clarification, Dr. A. I'm happy to hear that there's so much anesthesia exposure before CA1. I'm sure a lot of us applicants are looking for that. And last but not least, I will ask this question to the Mount Sinai Morningside-West team. So I'll start with Dr. Choi.
Dr. Choi had to go. We have Dr. Salik, our chief, carrying the load.
Yes.
Just kidding,
sorry,
Dr.
we had to
Salik.
run, so it's just me.
Got it.
I think there's a lot of support with regards to transitioning from intern year to CA 1 year. Even before you start intern year, you're paired with a CA1 mentor who's just done intern year. And I think they're incredibly helpful for, even just before you get here, just logistics of moving and starting your very first rotation before day one. And then they're always there with you step by step as you go throughout the year and always there to support you. And in addition, we do a month of one of our rotations during intern year is a month of MICU. And during that month, you're paired with a CA1 anesthesia resident as well. And so kind of your MICU senior also becomes another mentor for you as you go through intern year. And then in addition to kind of the other rotations that we have on off services like medicine and surgery, we probably spend depending on what you do for your electives, you can spend upwards of 3 months in the anesthesia department on your intern year. So we do a month of acute pain. Our electives, oftentimes our interns choose to do them in things like PAT, our pre-admissions testing clinic, or PACU. And then we have a solid month of anesthesia in our intern year where we're paired with one-to-one with certain attendings. Mahoney likes to joke that he was my one-to-one, but really he only was for a week. And my true one-to-one has been with me for every step of the way. We go back with those same one-to-ones when we start again CA 1 year for the first month or so. And also during the first month of CA 1 year, we have kind of boot camp lectures. So we have 2 lectures in the morning and the afternoon for that first month to help kind of transition over. So I feel like there was a lot of support with regards to not only the transition from intern year to CA 1 year, but also just the transition overall to residency and every step throughout.
Got it. Thank you so much for that response. It sounds like you're also doubling down on the adjective of supportive. You get a lot of time with your one-to-one mentor, not only during your prelim year, but then again during CA1. So I can appreciate that continuity. And for the next question, I will ask Norbert to take over.
Thank you, Candace. So now that we have passed the hour, I'm going to be asking the final question of the night, kind of a question looking forward into the future. What is the biggest change you expect to see in anesthesia by the time we are hopefully attendings in more or less 5 years? Dr. Abramowicz, can you go first, please?
Right. So 5 years is not long enough for there to be major changes. So I think that in 5 years, because the average age of an anesthesiologist in the United States, something in the order of 56 or so. So there'll be more retirements. And I think the job market for the next 5 years definitely will continue to be extremely strong, which means that you can look forward to compensation figures that are probably just appearing in your dreams as something that's not achievable, but it will be. So that's one. The type of practice, I think you're gonna basically see a major change in the employer's recognition that we're all human beings and nobody can work 80 hours a week for the, constantly. So there's a lot of flexibility in the work schedules that are being offered. There are jobs where you work a lot, but then you're off for many weeks. One of my residents just signed a contract in Texas. He's going to be off 14, I think, weeks out of the year or something like that. But in exchange, there's going to be weeks where he worked continuously for 7 days or something. So you will see a lot of these hybrid schedules where you work a lot and then not at all, or maybe you work part-time during the week, etc. So I think that is dramatically changing. I think that as a result of us having become, for the most part, employed by hospitals, hopefully that private equity piece is going to collapse soon because it's completely ruining the healthcare at this point. I hope you guys know what's going on with the Steward system and the real estate. Right. So these hospitals are closing. The state of Massachusetts is going to take over St. Elizabeth's, which is a major hospital, and a bunch of community hospitals are at risk of closing there because of all these problems. So anesthesiologists who work for hospitals are required really to be very versatile, and they have to do all kinds of stuff. Not just, give anesthesia, but they also have to develop some expertise in leadership, in QI, patient safety, and perioperative work. So I think those fellowships that are springing up and they're not accredited yet in perioperative care are going, and preoperative optimization and things like that are going to be increasingly more important. So we have to teach residents how to do it. And I think critical care also. I mean, I can tell you there's a difference. We have a trauma critical care fellowship. There's a big difference between how patients are managed by anesthesiologists, intensivists, and trauma critical care people. I mean, I don't want to be critical of them because they work very hard and they save lives when they go to the OR, and do these amazing open procedures, but their critical care skills, this is not the same. So that's where I see it going. And I am a little worried about, the recruitment landscape, if I can go beyond 5 years, because I think that the number of programs and the number of residency spots is exploding. And at some point, we're going to have the emergency medicine bubble. And I'm watching this with some trepidation, because I've been through this once, because I've been around for a long time, and it's never a good thing. But for now, I think you guys are going to be in very, very good shape for a long time.
Thank you. Yeah, as someone who witnessed the emergency medicine bubble and has read about it, I also share those concerns as well. Dr. Mahoney?
Oh my God, this is the best question for the very end. But the answers might be kind of boring to you, although they thrill all of us. Dr. Abramowicz nailed a lot of it. I mean, the economics play a huge role. Speaking of the emergency medicine bubble, that was a combination of things. They were trying to staff ERs, and then they changed a lot of the laws around staffing ratios. So that was like a bit of a red herring. Luckily for us, even if you combine all of the CRNAs being trained with the anesthesiologists, we're short right now. So I think she was right in saying that it's really not a 5-year time span, but a 10-year time span to look at the changes that we expect to see. And yes, we're going to have a lot of new programs, a lot of expanded programs. But I think, like most things, when I teach my pulmonary physiology and tidal volumes, it'll be just like that, last in, first out. So all these new programs will probably be the first ones suffering from an inability to fill 5-10 years from now, but we won't. We've been fine. Dr. Abramowicz, Dr. Romanelli, they have great established programs. We'll all be fine and watch our poor colleagues, like in the distant reaches of other boroughs, having a hard time. You guys are going to be good. You're going to keep seeing the great contracts and everything you're seeing now, 5 years from now. When you graduate, you'll be seeing a lot of the really great offers, I think. However, the next 5 years, things will change. If you want to do this amazing locums, work like, 6 months out of the year total, make the same money as the three of us sitting here talking to you are making, do it immediately, because once the shortage goes away, so do the really, really choice contracts. Once these companies, and yes, hopefully private equity will start to lose some power, but the hospitals basically are copying a lot of the same business practices, even though they're in nonprofit centers, are going to take their revenge on everyone. And guess what? Y'all taking call then. So enjoy it now, because it will go away, but you're lucky, because technology is always the the thing that you can't predict, and that changes the world the most. And technology is somewhat unpredictable. AI is going to take away your fiance who's applying for radiology's job, but AI ain't taking away your job because we combine both the brains and the manual stuff. Oddly enough, even surgery could go to AI before we can because they're focused on one small area and a little robot can do the stuff. Like when your surgeons are using the Da Vinci robot, that's all being fed into AI at the same time. And then one day they're going to say, we're taking our robot back and your patients because now our robot can do all the stuff that you can do. But we are moving around in the operating room. We're very safe. We're always going to be necessary. We have a couple of things going on at the same time. We're totally necessary with this unique skill set, matching the manual dexterity and skills with the mental capacity, the fast thinking. There's no right answer. What do I do if your attending's answer is always, it depends. There's too much going on. At the same time, we've all been converted into employees. We used to own practices. We used to be doctors and professionals. I don't think if you look at our class in society, professional is the right word anymore. We're employees. We're the proletariat. We're like a really, really smart version of people working in auto factories, but we're really smart and our job is way better and it's much more exciting. So our relationship towards the employers is going to change. They're never going to get better. They're going to keep on getting bad. Maybe our future is not as ASA members. Maybe it's as members of a labor union. I think that's a better footing for us because that's more descriptive and representative of our role in society and the economy. Stop thinking that you should vote with the party that's going to cut taxes because your taxes will always be high because you earn it through labor and not through investments. Recognize the class you are joining. You are joining the working class. I am proud to be a worker. I love being there with my colleagues, the nursing staff, the janitorial staff, the security. Those are my people. The C-suite, I'll chuck them off a ledge as soon as I can. They are not our friends. So maybe you guys will be part of the revolution, changing that power balance. People respect doctors. We do something valuable for society. All I know is it's going to be thrilling. It's going to be exciting. You are entering a field in which people need you. You are going to save lives. And this job is not going to be going away. And you'll be very well compensated, don't worry.
Great. Thank you so much. I'm sure I speak for everyone that you've helped confirm for us that we're going into the best field possible. All right, Dr. Romanelli.
With all that context, all I could probably offer you guys is some advice is how to try to navigate, what, is coming down the line essentially. And like I said before, we don't have a crystal ball, but this is likely where we are heading. So it's really just important, above all else, embrace innovation, become POCUS adept. That's going to become the most valuable skill that anyone can have in their armory. It's basically already integral to our daily practice. And so developing proficiency in it is super important. It's going to really set you apart and enhance your clinical decision making. Don't underestimate the importance of having financial literacy, understanding the business side of medicine. That's going to be crucial as all these healthcare models shift around and all these new payment structures start to emerge. I still would say, find a niche for yourself, consider fellowship training, even if it's not in vogue at the time. I'm hoping everything's kind of cyclical and we might go back to how it was 5 years ago, but there's certain things you can do to, otherwise elevate your expertise and again, carve out a niche for yourself, distinguish yourself. There's going to be other mid-level providers who can do just about the same things that everyone else can do. So what is it that basically sets you apart? I know people who did dual fellowships, like Kirk's going to do cardiac and ICU. I know someone who did OB and cardiac and is now the go-to person for all cardio-obstetric care for anyone who's like a pulmonary hypertensive, and they go visit her down in North Carolina just because they're seeking out the anesthesiologist, which is unheard of, but to take care of them and get them through their delivery. And I learned so much as an attending in the first 2 years as being an attending. There are things that I try to incorporate into my residency program now, specifically for our third-year residents as they are now preparing to become attendings, but maybe I didn't have, say, 10 years ago in our program. But, embrace taking call as an attending. Don't shy away from those. That's where you're going to learn the most. So, you're going to hear about positions that don't involve taking call or, there's no weekends or anything, but try to, in that first or second years out, if you're able to do so, really challenge yourself at all times. And that's going to bode well for how you eventually do with board certification, especially if you know you're going to be a little remote from it, especially after you graduate from residency. It still takes another 7 or so months before you even get to sit down for your OSCEs and your oral boards. So make sure that you are continuing to hone your craft. So, but the changing landscape, that's just something that we're all going to have to navigate together. And that's what hopefully residency programs are tailoring their programs to, preparing you for that job market, which for now, right now, it's again, the Jack and Jacquelines of all trades that we're trying to make sure that you're proficient in a little bit of everything, and that we anticipate that they're going to make you try to go from one place to another. So, you know, just kind of be ready for that, and, you know, be the best you can be and versatile in all those elements.
Great, thank you. Resonating with what you said about fellowship, I know many of my classmates, including myself, are also considering doing fellowship just because we're not rushing into the job market right away. We want to continue to learn and continue to specialize. So that was our last question of the night. So I'm going to be moving into conclusions. Please stick around though, if you're viewing on YouTube, for additional information at the end. But of course, first and foremost, huge thank you to Dr. Abramowicz, Dr. Mahoney, and Dr. Romanelli for speaking with us today and sharing valuable information about all of their programs. Round of applause. Additional thank you to all of the residents for taking the time to join us as well. I hope those who tuned in learned as much as we did about these unique programs. To all the registrants, you'll be receiving an email with additional information about each of these programs tonight. As a reminder, this is the first panel of 3 in our series this year. Look out for our follow-up emails for future panels. Our next one is next week, Thursday the 29th, featuring Quinnipiac, Stony Brook, Northwell, and our new program director at Westchester Medical Center, Dr. Smith. Once again, thank you to the program directors for joining us tonight. I think I speak for all of us that we really appreciate your time and the insights that you gave us tonight. Have a great rest of your night, everyone, and thank you all for coming. Bye.